Hello, everybody. My name is Anand Vaidya. I'm at Brigham and Women's Hospital, and I'm an endocrinologist, and we'll be talking about adrenal disorders. I have no disclosures. So the objective of this talk is to give you a broad overview of a variety of adrenal disorders. We will review the role of the adrenal gland in physiology and pathophysiology. A lot of my topics will focus on physiology, as I think that's the best way to understand them. We'll spend some time talking about adrenal insufficiency, how to evaluate an adrenal mass, and we'll touch on the workup for hyperaldosteronism, hypercortisolism, and pheochromocytoma. These are guidances for internists and generalists. They're not going to be complete and comprehensive. They're what I think are the most practical lessons for a busy internist. If you fall asleep or check out or forget what I said in the future, many aspects of this lecture are on YouTube, and you can watch them at any time. Okay, so this is going to be case-based, and this is the first case. There are going to be 5 cases. This is a 28-year-old woman, and she's coming to the emergency room 6 weeks postpartum after having a baby, and she's unable to breastfeed. She's having progressive fatigue, dizziness, orthostatic hypotension, feelings of lightheadedness when she stands, salt cravings. She's noticed that her skin has become much darker throughout the pregnancy and even postpartum. She has no appetite, and she's losing weight. Her blood pressure is very low in the emergency room, 60/40. She's given up to 8 liters of IV normal saline, and her blood pressure stabilizes. And someone thinks about adrenal insufficiency, so they check a cortisol, which is 0.8 micrograms per deciliter. The accompanying ACTH is over 1,000 picograms per milliliter. And someone does a cosentropin stimulation test where they give exogenous ACTH, and an hour later, the cortisol rises from 0.8 to 1 microgram per deciliter. So based on this vignette and the labs, what do you think is going on? Do you think this is primary adrenal insufficiency, acute secondary adrenal insufficiency, chronic secondary adrenal insufficiency, ectopic ACTH syndrome, or Cushing's disease? Okay, so hopefully many of you thought this was adrenal insufficiency, and if so, that it's primary adrenal insufficiency. And what I'll do now is walk you through the variety of different ways adrenal insufficiency can manifest and the underlying physiology. So to understand adrenal insufficiency, we need to understand the adrenal cortex, which is responsible for adrenal steroidogenesis. There are 3 broad histologic layers and functions: the zona glomerulosa, zona fasciculata, and zona reticularis. Cholesterol is used as a backbone substrate to synthesize aldosterone in the zona glomerulosa, cortisol in the zona fasciculata, and to a topic we're not going to really touch upon a lot, adrenal androgens in the zona reticularis. So we're going to really focus on aldosterone and cortisol. And to understand how these hormones work, you really need to understand what their receptors do. So there's a hypothalamus, pituitary, adrenal, and then there are the receptors, the glucocorticoid receptor and mineralocorticoid receptor, which are expressed all over the body. So what do these receptors do? We learned about what the glucocorticoid receptor does based on syndromes of cortisol excess, like Cushing syndrome, and cortisol deficiency, adrenal insufficiency. It's really hard to completely capitulate what it does in normal physiology, but here are the major points. Cortisol activates the glucocorticoid receptor to increase blood glucose, gluconeogenesis, lipolysis. It maintains vascular tone. The pressor response to norepinephrine and catecholamines is mediated through cortisol interacting with the glucocorticoid receptor. Cortisol plays an important role in immune modulation, variety of central nervous system effects. It's important for fetal development and parturition, induction of labor. And I like to say many other magical things. Cortisol is important for just about every bodily function and organ function. Its deficiency or excess can wreak havoc on almost every organ system. It's much easier to understand what physiologic activation of the mineralocorticoid receptor, classically expressed in the kidney, does. Activation of the mineralocorticoid receptor increases sodium reabsorption, which this is the main osmole of the body, so it causes expansion of plasma volume, and in exchange, there's excretion in the urine of potassium and hydrogen ion. So if we go back to the physiology, the hypothalamus secretes corticotropin-releasing hormone. The pituitary responds by secreting ACTH, And in parallel with ACTH is the secretion of melanocyte-stimulating hormone. We'll talk about that briefly. But ACTH is the key hormone that circulates through the blood and then tells the adrenal cortex to produce adrenal steroids. So the main one is cortisol. Cortisol floats around in the blood, and it can interact with the glucocorticoid receptor in any cell that expresses it. And that induces a variety of gene transcription and tissue-specific effects. But this glucocorticoid receptor is also expressed centrally in the hypothalamus and pituitary, which acts as a sensor for cortisol and maintains a negative feedback and equilibrium. It's called the negative feedback loop and a complete homeostatic equilibrium. So what people often forget is cortisol is also a mineralocorticoid. It can activate the mineralocorticoid receptor. And this process is heavily gated by an enzyme called 11-beta hydroxysteroid dehydrogenase 2, 11-beta HSD2. And the reason it's a gatekeeper is because it inactivates cortisol to cortisone, which is inactive, and is co-expressed with the mineralocorticoid receptor. So in other words, although cortisol is a very potent mineralocorticoid, just as potent as aldosterone, it is inactivated and does not physiologically activate the mineralocorticoid receptor very much in normal physiology. And that's important because cortisol circulates in the blood in 1,000-fold the concentration of aldosterone. You can see aldosterone floats around in nanograms per deciliter, cortisol is in micrograms per deciliter. So you have 1,000 times as much cortisol as aldosterone, and it's an equipotent mineralocorticoid. But aldosterone, despite being in a low concentration, serves as the main mineralocorticoid of the body because most of the cortisol is inactivated once it gets to the mineralocorticoid receptor. So aldosterone is the other adrenal corticosteroid that we'll talk about, and it's regulated in part by ACTH, but independently by angiotensin II, the renin-angiotensin system, and independently by potassium, hyperkalemia. All three of these can stimulate adrenal aldosterone production, and even though aldosterone is a very low in concentration compared to cortisol, it has a high affinity relationship with the mineralocorticoid receptor. It's a pure, potent mineralocorticoid. So the key lessons here are: one, cortisol secretion is entirely dependent on ACTH. In other words, if you lose ACTH, you do not make cortisol. So that's a key thing to remember. Two, aldosterone is not dependent on ACTH. Yes, ACTH is a secretagogue of aldosterone, but so is angiotensin II, and so is potassium, meaning if you lose ACTH, you will still continue to have normal aldosterone physiology. This is a key point that we'll come back to in a moment. And three, this entire hypothalamic pituitary adrenal axis responds to diurnal variation, I'll show you an example, and stress, usually physical stress, but also psychological stress. When your body is stressed, ACTH and cortisol are augmented relative to that degree of stress. So the brain knows how much to increase cortisol production depending on the stress, whether it be surgery, critical illness, mild pain, or psychological stress. So here's an example of diurnal rhythm. You can see that cortisol levels rise in the morning, they peak early in the morning, and then they dwindle down throughout the day and are very low. They nadir around midnight and then only to rise again. This is time to sunrise and sunset. So you can see how difficult it is to know what a normal cortisol is. Here's actually real tracings from people. You can see that this is not a cartoon. These are really low nadirs at night, rise in the morning, and dwindle down. And everybody's different. So how do you measure cortisol? What is normal? If it goes all the way from 0 to 25 micrograms per deciliter throughout the day, how do you measure it? So one easy static test that can assess the entire hypothalamic pituitary adrenal axis is measuring a morning cortisol, and ideally with an ACTH. Now the goal here is you're going to try to capture the peak morning cortisol rise as a reflection of how the whole system is working well. And an appropriate morning cortisol is ideally double digits, 15 to 18 or higher micrograms per deciliter, reflecting you've got a good morning peak. But you have to remember every person is different, and in that cross-section in time, you may have missed the peak by an hour or two or been too early, so you have to have some wiggle room. And if your pretest probability is not high, even values that are double digits, 10 to 12 or higher, might be okay. If the morning cortisol is very low, less than 5, this is almost definitely adrenal insufficiency, and values in between are indeterminate. You need more testing. So this is a crude way to test the entire hypothalamic pituitary adrenal axis, but the gold standard is a provocative test that tests adrenal function. This is a concentropin stimulation test, sometimes in short called a court stim test, where you give a supraphysiologic amount of ACTH exogenously, and you look to see how much the adrenal glands can respond by increasing cortisol production. And generally speaking, this somewhat arbitrary designation has been established, where if the cortisol doesn't rise by above 18 micrograms per deciliter, this is suggestive of a suboptimal reaction. So this is a more laborious and intensive procedure. The static test is an easier, crude process that can be used. So now let's look at primary adrenal insufficiency, sometimes referred to as Addison's disease. So in this condition, it's called primary because the entire adrenal cortex, and remember you have two adrenal glands, so both adrenal cortices are non-functional or have been destroyed. Okay, so that means you don't have an adrenal cortex, so you cannot produce adrenal steroids. That means there's no cortisol and there's no aldosterone. These are vital hormones. You cannot live without them. So in the absence of cortisol, the hypothalamus and pituitary will sense a lack of negative feedback and upregulate CRH and ACTH production. This is really an endogenous court stim that's happening. ACTH is screaming at the adrenal gland, give me cortisol, but the adrenal gland cannot respond. Okay, so what happens here? The biochemical characteristics are a low cortisol, a very high ACTH, which is a physiologic compensation. But these patients also have low aldosterone, and over time they will develop hypovolemia, hyponatremia, and hyperkalemia. On physical exam, these patients can present very ill, fatigued, tired, anorexic, but the critical illness is hypotension, orthostatic hypotension, salt craving, losing weight, and hyperpigmentation, not only because ACTH is high, but also melanocyte-stimulating hormone, as I mentioned earlier. And when they present this critically ill, it's a real problem. This hypovolemia has been going on for a long time, and they're about to enter a cardiogenic shock or a hypovolemic shock situation. So you could do a cosentropin stimulation here, but you can see they already have an endogenous ACTH stimulation. If you did an exogenous challenge, you would confirm that there is a suboptimal cortisol response. And here's an example of what labs in someone with primary adrenal insufficiency would look like. Very low morning cortisol, a very high ACTH, and if you did an exogenous court stim, a very suboptimal response. And so that's the exact labs that our patient had. So she has primary adrenal insufficiency postpartum. So what causes primary adrenal insufficiency? Anything that destroys both adrenal cortices. The most common is autoimmune. In other parts of the world or in immunocompromised populations, tuberculosis, fungal infections, or anything else that can cause bilateral hemorrhage, bilateral malignant infiltration, congenital adrenal hyperplasia, adrenal leukodystrophy. There are some medication effects that are not very common that can also occur. Okay, so now let's contrast secondary adrenal insufficiency with primary adrenal insufficiency. In secondary adrenal insufficiency, the problem or the lesion is at the level of the hypothalamus or pituitary. In other words, the adrenal glands are fine, but the ability to make ACTH has been compromised. So the pituitary doesn't make ACTH, and since cortisol is 100% dependent on ACTH, in the absence of this stimulatory signal, the adrenal glands do not make cortisol. So you can see the adrenals are healthy and fine, but they're just not receiving a signal to make cortisol. So the biochemical manifestations of secondary adrenal insufficiency are a low cortisol with an inappropriately low ACTH. Aldosterone is being produced because angiotensin II and potassium can continue to stimulate adrenocortical aldosterone production. So typically these patients are normocalemic, but the physical characteristics can vary. In the absence of a stressor, even with a very low cortisol, patients may feel fine. With progressive stressors, they may develop mild progressive fatigue, and in severe stressors, you may develop a full-blown picture that looks like an adrenal crisis, orthostatic hypotension, depending on the degree of stress. In acute secondary adrenal insufficiency, where the deficiency of ACTH has been short-lived, days or a few weeks, an exogenous cosentropin challenge will result in a robust cortisol production, okay? Because the adrenals are fine. So typical labs of acute secondary adrenal insufficiency are a low morning cortisol and inappropriately low ACTH. So this designates secondary adrenal insufficiency, but a robust response to exogenous cosentropin. That tells you that this ACTH deficiency has only been going on for a short period of time. If this ACTH deficiency becomes chronic, it goes on for weeks or months, ACTH is not only a secretory hormone, it's also a trophic hormone. And in the absence of ACTH, the entire zona fasciculata will gradually atrophy, just like a muscle that's not being used. And the adrenal's ability to respond to ACTH will progressively decline. So with chronic ACTH deficiency, an exogenous cosentropin stimulation will be suboptimal. And labs in that case might look like a low cortisol with an inappropriately low ACTH and a suboptimal stimulation. So what causes secondary adrenal insufficiency? Anything that harms the pituitary or hypothalamus and renders it incapable of making ACTH. But the most common cause is iatrogenic. The use of exogenous glucocorticoids, dexamethasone, prednisone, prednisolone, solumedrol, because these glucocorticoids tell the hypothalamus and pituitary to stop producing ACTH. Okay, so this patient was diagnosed with primary adrenal insufficiency, Addison's disease. She was treated with IV saline and stress-dosed IV hydrocortisone. She recovered and then was transitioned to an oral regimen of hydrocortisone and fludrocortisone for life. And these patients should always be managed in conjunction with endocrinologists. So I'm not going to go through the nuances of the management. The diagnosis and recognition is the most important for general internists. Okay, let's go to case 2. This is a 46-year-old premenopausal woman who is in a car accident. She has no known medical conditions. And she's brought to the emergency room and is complaining of abdominal pain. So she has a rapid unenhanced abdominal CAT scan, which doesn't show any hemorrhages or internal injuries, but there's an incidental finding of a 2.2 centimeter right adrenal mass. It has an unenhanced CT attenuation of 5 Hounsfield units on the report. So what do you tell this patient about this adrenal mass? And the brief summary of the next dozen slides is never ignore an adrenal mass. Okay? If you don't know how to work it up or you don't have time to work it up, refer it to an endocrinologist. If you do have the time, work it up yourself, but don't ignore these masses. The biggest problem here is most of them are ignored or lost in follow-up, and you'll see why that's important. So incidentally discovered adrenal masses are common. About 1 to 10% of all adults who undergo an abdominal cross-sectional scan, MRI or CT, are found to have an adrenal mass incidentally. So that's a lot of people because there's millions, really hundreds of millions of scans per year worldwide. Most of these are not cancer. I mean, one of our concerns is this mass a cancer, a malignancy? Turns out most are not. But even benign adrenal masses can be dangerous because they can secrete adrenocortical hormones like cortisol or aldosterone that can contribute to increased risk for cardiovascular and metabolic diseases like diabetes, heart disease, hypertension, osteoporosis, and fracture. And so for that reason, it's recommended that every incidentally discovered adrenal mass should be carefully evaluated for 1, is it malignant or benign? And 2, is it functional in any way that needs intervention or not? So the differential diagnosis of an adrenal mass is best considered through this lens: benign or malignant, functional or non-functional. Unfortunately, the vast majority of adrenal masses will turn out to be benign and non-functional, with the dominant etiology being a benign, non-functional adrenocortical adenoma. Here's a list of other potential entities that are less common. The second most common is a benign adrenocortical adenoma that is functional. It's either making aldosterone or cortisol, and sometimes it's not a discrete adenoma, but micro or macronodular disease, which are multiple small adenomas. Another entity is a benign pheochromocytoma that's producing hormones. Malignant entities are rare unless you work in a center or practice that's connected to a tertiary care cancer center. Then you might see a lot of metastatic cancer from non-adrenal primaries, and almost all of them can do that, especially with longer cancer survivorship. But the main primary adrenocortical malignancy we worry about is adrenocortical carcinoma, which can be non-functional, but very often functional. So the general diagnostic approach as a clinician is there any evidence for malignancy? Is there any evidence for adrenal hormone excess? And the approach involves evaluating each of these through the clinical, biochemical, and radiographic lens. So this is how you do it. First, you look at the patient and you say, do they have any clinical characteristics of malignancy, but also of adrenal hormone excess? Meaning, do they have any signs of Cushing's syndrome? Do they have any signs of pheochromocytoma? Do they have any signs of hyperaldosteronism? And I'm not going to go through each of these because I think most people know what these syndromes cause. But the truth is, most patients won't have obvious symptoms, right? Because this was an incidental finding. Very occasionally, you will find that someone has these symptoms that are just being detected and you can connect the two. But most often, as in the case of this patient. Patients don't have any obvious symptoms of hypercortisolism, pheochromocytoma, hyperaldosteronism, or hirsutism, or any B symptoms or other concerning signs of an underlying malignancy, and the clinical phenotype is often unrevealing, as it is for this patient. Then you look at the radiographic phenotype. I would recommend looking at the images yourself, but at the minimum, look at the report. On the left here is a example of what normal adrenal glands look like. They look like the letter Y upside down or splayed out. This is the right and left adrenal. So you can see they're very tiny, wispy, elegant organs. And here's the patient's non-contrast CT. And this is a little glimpse of a segment of the left adrenal, which was normal. But here's the right adrenal, and it's a mass here that's a 2.2 centimeter, 5 Hounsfield unit attenuation mass that's round and homogeneous. And 5 Hounsfield unit, you can see it's kind of on the darker side, which suggests that it's pretty fatty. So what do you think this is? A 2.2 centimeter adrenal mass with an unenhanced CT attenuation of 5 Hounsfield units is most likely a myelolipoma, an adrenocortical adenoma, a pheochromocytoma, metastatic lung cancer to the adrenal gland, or an adrenocortical carcinoma. So this is almost definitely an adrenocortical adenoma, and I'll explain why. So here is a table that gives you characteristic features that might make you think that something is benign or malignant. Now, these are not foolproof, these are generalizations. So irregular shape of a mass, heterogeneous content, necrosis, calcifications, or rapid rate of growth over time, if you see them, are all potentially concerning features. Not necessarily indicative of malignant, but you'd be more concerned about something being malignant. CT attenuation without contrast, that's what we had in this case. 0 Hounsfield units is the attenuation of water. The lower the attenuation, the more fatty it is. The higher the attenuation, the more vascular and dense it is. So typically anything less than 10 Hounsfield units is considered to be fatty or lipid rich. So hers was 5 Hounsfield units, and fat is good. That tells you that this is almost definitely benign. So that's a reassuring feature. If you want to do a washout protocol, then where you look at, you give contrast and then you wait 15 minutes to see how much contrast disappears. Fatty things tend not to be contrast avid and will release most of their contrast. They'll have a high washout. Non-fatty and vascular things tend to have a poor washout and might be more concerning. You can also get a sense of fat content on MRI, which can be done with chemical shift or in and out of phase imaging. FDG avidity on a PET scan is generally a concerning sign. And the larger the size, the more concerned you should be. This is not a hard and fast rule, but it's a general rule. So you'd have to put a lot of these together. So this patient has a small, round, homogeneous mass that is 5 Hounsfield unit, less than 10, so consistent with a small, round, lipid-rich lesion, and is very reassuring that this is a benign entity and almost definitely an adrenocortical adenoma. And that's the most common diagnosis. So we've looked at the clinical phenotype, we've evaluated the radiographic phenotype, we think this is benign and we think it's an adenoma. So last we have to look at the biochemical phenotype. So the advice is that every adrenal mass should be assessed for these biochemical parameters. Number 1 is hypercortisolism. This is the most common functional anomaly in adrenal masses, and every patient with an adrenal mass should have an assessment for hypercortisolism, whether you do it yourself or you refer to your endocrine colleagues. The recommended test is a 1 milligram dexamethasone suppression test, where 1 milligram of dexamethasone is taken close to midnight, and the following morning at 8 a.m. or around 8 a.m., 7 to 9 a.m., a morning cortisol is measured. And what you want to see is that dexamethasone turns cortisol production, ACTH and cortisol production, down to 0. Ideally, a normal value is less than 1.8 micrograms per deciliter. That's considered a non-functional adrenocortical mass. Any cortisol value greater than 5 after dexamethasone is consistent with mild hypercortisolism or autonomous hypercortisolism or mild Cushing syndrome. There's a variety of terms and nomenclatures, and in between is kind of an indeterminate finding. Primary aldosteronism, we'll talk about that later. Any patient with an adrenal mass with hypertension or hypokalemia should have an aldosterone or renin measured, and you're looking for a low renin and a relatively high aldosterone to be suggestive. Pheochromocytoma, if it's a benign appearing fatty lesion, less than 10 Hounsfield units, the likelihood of a pheochromocytoma is close to 0%, so you don't need to test. However, if it's a lipid-poor mass, you should make sure that it's not a pheochromocytoma. You never want to miss those. And plasma fractionated metanephrines or urinary, either could be done, and we'll talk about that later. we almost never recommend measuring adrenal androgens unless there are clear signs of viralization, particularly in women, hirsutism, or other viralizing signs. So this woman has a benign adrenocortical adenoma, but on her 1 milligram dexamethasone suppression test, the cortisol doesn't go down. It's still 8 micrograms per deciliter, which is less than 1.8. So step 1 is make sure she took the medicine. She said she did. The test is repeated, and it's still about 8 micrograms per deciliter, and you can see ACTH here is fully suppressed. So she did take the dexamethasone. You have a good dex level. It worked. So this looks like autonomous cortisol, and for good measure, you do a high-dose dexamethasone test, and it still doesn't suppress. So this is very suggestive of an adrenocortical source of autonomous cortisol production, and this is a little bit more esoterics that usually your endocrine colleagues could help you with. She has a borderline urinary free cortisol. She has 2 borderline high late-night salivary cortisols, all consistent with autonomous cortisol production, low ACTH, low DHES, all consistent with autonomous cortisol production that's independent of ACTH. This all suggests that this benign adrenocortical adenoma in an asymptomatic patient is actually producing a little bit too much cortisol, even though it's not causing the full-blown Cushing's syndrome. So this is a woman with an incidentally discovered benign adrenocortical adenoma that has evidence of mild autonomous cortisol production, even though she has no clinical signs of hypercortisolism. So what should you do? Okay, so there's a lot of controversy around this, because if she doesn't have Cushing's syndrome, why should you care? And a lot of consistent and repeated data has shown that this anomaly of mild hypercortisolism does increase the risk of a series of metabolic diseases, impaired glucose tolerance, full-blown diabetes, low bone density, osteoporosis, fracture, and cardiovascular disease. What we don't have is randomized controlled trials that say that if you intervene on this, you will reduce the likelihood of any of those outcomes occurring. And so we're still at a point where individualized decisions need to be made. So this patient, for example, had normal blood pressure. She had normal blood glucose and hemoglobin A1C, but this is a premenopausal woman who has incidental osteoporosis. This evaluation was done to look for signs of hypercortisolism. She has a pretty extensive workup for secondary causes of osteoporosis, which is negative except for the mild hypercortisolism. So what to do? Follow or do an adrenalectomy to remove that tumor. In this case, an individualized decision was made to perform a laparoscopic right adrenalectomy to remove that mass, because it was deemed that that high cortisol was likely the main contributor of this bone density. Okay, so this is an individualized decision. And once this tumor was taken out, it was indeed an adenoma. Her post-op cortisol was 4 with a suppressed ACTH. In other words, the contralateral gland and the hypothalamic axis was suppressed. That's actually reassuring. It means that you did take out a source of autonomous hypercortisolism, and the HPA axis recovered the next week. Okay. So I'm going to put together all of this into a diagnostic algorithm that outlines what you should do when you see an adrenal mass. Okay, so an incidental mass is seen on a CAT scan or MRI done for another reason. You should first evaluate for clinical signs and symptoms of adrenal hormone excess. That's a history and exam. Then you do biochemical assessments and evaluation of the radiographic characteristics. If you find that there's overt biochemical excess, Cushing's syndrome, pheochromocytoma, primary aldosteronism, the solution is almost always confirmation and then consideration of surgery, especially if it's unilateral. And you should work with your endocrine colleagues or other specialists to decide how best to do that. If it's a non-functional mass or one that has mild cortisol excess without a clinical syndrome of Cushing's, like we just talked about, first look at the radiographic characteristics. If they're suspicious, they don't look lipid-rich, they don't look reassuring in other ways, meaning you're concerned for a malignancy, and it's unilateral, you're almost definitely going to pursue surgery. And if you're not sure, sometimes that happens, you're either going to pursue surgery to find out, or you'll follow up very closely, and any change that makes your concerns worse or doesn't reassure you will probably be addressed with surgery. Sometimes people ask, what's the role of a biopsy? The role of a biopsy is pretty small. It's never used to distinguish a primary benign or primary malignant adrenal process. It's not good enough to do that, and there are other risks by doing that. A biopsy can help tell you if this is an extra adrenal metastasis to the adrenal, or, especially in an immunosuppressed person, if this is infiltration by an atypical infection, fungal or other. Okay, and so usually the history gives you a clue of that, and if you suspect that, it might change your management. If this was stage 4 metastatic cancer or fungal infections, a biopsy would tell you that you need to treat with a particular chemotherapy or antimicrobial, and so you should consider that. Otherwise, you're in a category where you're have an adrenal mass that's typically non-functional or mildly functional and has benign or reassuring features like we've seen in this case. So what do you do in that scenario? Okay, this is the most common scenario. So first of all, there is no evidence or indication to repeat longitudinal imaging. In the past, people used to follow these with repeated CAT scans year after year. Longitudinal studies and large meta-analyses have shown that once you have seen a lipid-rich, benign-looking lesion, the likelihood that it will transform to something malignant or grow appreciably is extremely low, almost zero. So you don't need to keep imaging it year after year. So that's step one. If it's non-functional, if there were no other concerning biochemical parameters, no reason to keep following it unless something dramatic changes in the subsequent years. The patient develops signs that make you concerned about Cushing's syndrome or hyperaldosteronism, sure, then you can do biochemical testing. Otherwise, no indication for repeat biochemical or radiographic surveillance. If, on the other hand, you find mild or autonomous cortisol secretion without obvious Cushing syndrome, as there was in this patient, you have to make an individualized decision to follow or intervene. And you either intervene like we did in this case, or you follow closely with repeated biochemical surveillance and assessment for other comorbidities to decide when you might do so. And of course, you're going to work with your colleagues in endocrinology to decide best when to do that. Okay, let's go to case 3. Now we can put together all of the things we've learned to address the next 3 cases. This is a 42-year-old healthy woman who has new onset hypertension, at first 130 to 140 over 80, so mild. But then one day she developed a spontaneous headache while at a sporting event and eating hot dogs and other salty foods. Her blood pressure is 200 over 100 with a headache, and she started on antihypertensives. And over several months, her antihypertensive regimen is escalated to lisinopril, amlodipine, labetalol, but her blood pressure is still 140 over 90. And on more than one occasion, she's had hypokalemia, pretty substantial, 2.3 millimoles per liter. So hypertension, 3-drug hypertension with hypokalemia should make you concerned for a mineralocorticoid excess state, like primary aldosteronism, but also Cushing syndrome, right? Because Cushing's is hypercortisolism, which is a mineralocorticoid and can present with hypertension and hypokalemia, but she has no obvious signs of hypercortisolism, so it's more likely to be hyperaldosteronism. So who should you screen for hyperaldosteronism? So for a long time, and even in many current guidelines, the indications to screen are severe or resistant hypertension with hypokalemia. And this is an extremely severe indication. Many experts recommend broadening that indication to suggest screening almost all hypertensives or at least all 2-drug or resistant hypertensives, because the prevalence of overt primary aldosteronism is greater than 20% in resistant hypertension and 10 to 15% in stage 1 to 2 hypertension. Okay, so if that comes as a shocker to you, it just shows how much the awareness is lagging behind the new data that's coming out. Anybody with hypertension and any type of hypokalemia, even if it's diuretic-induced hypokalemia, this is an indication to screen for primary aldosteronism. Hypertension with an adrenal mass, as we discussed, and hypertension with sleep apnea, or any suggestive sign of a familial form of primary aldosteronism, which is very rare. Okay, so in a one-slide nutshell, there's been an accrual of data that has suggested that the prevalence of primary aldosteronism is way higher than we have given credit to or have recognized. In resistant hypertension, meaning 3 to 4-drug hypertension, the prevalence is up to 24%. Even in stage 1 to stage 2 hypertension, a solid 15 to 20% have overt primary aldosteronism that is mostly just being completely unrecognized. Even if you look at the most severe indication, resistant hypertensives with hypokalemia, and you look at major academic medical centers, Stanford, Chicago, institutions in Boston, the number of people with hypertension and hypokalemia at these institutions who are being screened for primary aldosteronism is under 3%. Okay, so this is an absolute indication to screen, and it's under 3% of them ever have a renin and aldosterone measured, and most of these are resistant hypertensives. Okay, so there's a huge problem here. You are not screening for primary aldosteronism enough. So if there's one takeaway point in this section, is that if you have patients with hypertension, be much more liberal about screening for primary aldosteronism with a renin and aldosterone at minimum in anybody with any form of hypokalemia, anyone with 3-drug hypertension. It should be automatic. What should you measure? It's easy. A renin and an aldosterone from the blood by venipuncture. How are you going to interpret the test? So for primary aldosteronism, the renin has to be low. It has to be suppressed. And in the context of a suppressed renin, the aldosterone has to be relatively high. And we can debate as much as we want how high it should be, but if you want to be sensitive at picking up as much primary aldosteronism as possible, a good middle of the road number is 10 nanograms per deciliter. So if you have a suppressed renin and an aldo of 10, you should definitely consider this a positive screen. An aldosterone to renin ratio will generally be well above 20 in this situation. And at that point, you can counsel your specialist, whether that's an endocrinologist, cardiologist, nephrologist, it doesn't matter. And they can help you decide whether more laborious confirmatory testing, these are usually physiologic aldosterone suppression tests, need to be done or not, and how to proceed with localization, with imaging, adrenal venous sampling, etc. I won't get into the weeds on those because that's usually something that goes beyond the primary care level, and you can consult with specialists to help you do that. The goal for you is to screen the right patients, make sure you try to screen as much as possible, and then interpret the testing correctly so that you don't exclude true cases. So this patient had an aldosterone of 20 in the context of a suppressed renin. So this is autonomous aldosterone production. The aldosterone to renin ratio is going to be very high here. So this is a pretty obvious case of primary aldosteronism. In fact, it's so obvious, you don't need to do anything else. It's a confirmed case. You're done. Hypokalemia, 3-drug hypertension, suppressed renin, aldo of 22. It's pretty in your face. If you wanted to confirm it, you could do a variety of aldosterone suppression tests. This patient actually had an oral salt loading test, which should suppress aldosterone, and it did not. So this is a confirmed case of primary aldosteronism. And on CAT scan, here's her left adrenal gland. You can see this white upside down Y, and there's this little round dark ball hanging off of it. This is an adrenal cortical adenoma that was an aldosterone producing adenoma. It's not always this obvious. Sometimes they're almost barely visible on CAT scan or invisible on CAT scan or microscopic, but this is a pretty obvious example that I picked for you. Okay, so here's the diagnostic algorithm for primary aldosteronism. You have a clinical phenotype and biochemical phenotype that support the disease. You've confirmed overt biochemical primary aldosteronism. This is generally going to be handled with surgery. If it's unilateral, you ideally want a unilateral adrenalectomy to cure the disease. If it's bilateral on adrenal venous sampling, we usually do not do bilateral adrenalectomies, and patients are medically managed with mineralocorticoid receptor antagonists. And the goal here is either blocking or removing the aldosterone improves not only blood pressure and potassium, but improves blood pressure control in terms of antihypertensive medication burden and lowers overall cardiovascular risk beyond the effects of just blood pressure alone. So this patient had a laparoscopic left adrenalectomy. The pathology confirmed an adrenocortical adenoma, which was an aldosterone-producing adenoma. And postoperatively, she had a remarkable improvement in her blood pressure and required only a low dose of lisinopril. Hypokalemia was completely cured. So this is primary aldosteronism due to a benign left-sided aldosterone-producing adenoma, or sometimes referred to as a Conn's tumor. Okay, case 4. This is a 28-year-old healthy, athletic woman. She runs 4 to 6 miles a day, very fit, and she's complaining of excessive sweating. She has a desk job, and she finds herself sitting at work just breaking out in sweats all day long. She feels anxious. This is a new phenomenon, kind of like she's over-caffeinated or drinking too much caffeine or coffee. And her blood pressure in clinic is 140/90, which is new for her. The year before, it was normal, and she's an athletic, young, fit individual, so this is kind of eyebrow raising. She denies any palpitations, chest pains, or tremors, or any other symptoms that are not mentioned here. So what do you think is going on? And this is going to be a case of a pheochromocytoma, and I'm, not to spoil the surprise, but I'm intentionally presenting you a case like this because often physicians feel that a pheochromocytoma presents classically with a hyperadrenergic crisis or a catecholamine crisis. And that's true. If you wait too long, that can happen. But pheochromocytomas occur way before they present in crisis. And one of the presentations is mild symptoms of catecholamine excess, kind of hyperadrenergic symptoms like sweating and anxiety, like this young woman felt, and sometimes a little bit of an elevation in blood pressure. So who should you screen for a pheo or a paraganglioma? Anybody with a paroxysmal constellation or signs and symptoms that are concerning for catecholamine excess, and they usually should occur in spells, episodes that are consistent with surges in catecholamines being released. So episodic palpitations, sweats, anxiety, panic, elevations in blood pressure if they're measuring it, and if these are really severe, even headaches and visual changes. An important thing is sometimes people may describe pallor, whiteness of their face or complexion. But flushing is not a sign of pheochromocytoma. Flushing is a sign of vasodilation, not vasoconstriction. And flushing is not a symptom that you want to then use to evaluate for pheo and paraganglioma, because you're going to be stuck with more false positives than true positives. If you have anybody who has a provocation of one of these episodes by any type of medication, here are a couple of medications that are sometimes associated with catecholamine crises, but the reality is any procedure or medication that triggers a spell like this should make you think maybe there's a pheochromocytoma. Any adrenal mass that's not lipid-rich, meaning a lipid-poor mass on CT or MRI, should get a screen for pheochromocytoma. And anybody with a known genetic or familial syndrome of pheochromocytoma should, of course, be screened periodically. So what testing should you use? Okay, so maybe this is the most important slide on pheochromocytoma. The simplest way and highly sensitive way is plasma metanephrine. This is a venipuncture for metanephrine, and you will get fractionated metanephrine and normetanephrine fractions. If you want to do a 24-hour urinary collection for the same, you can. It's more cumbersome and difficult for the patient. There's no reason to do one or the other. They're both extremely good. You can see they're both excellent. They're done on LC tandem mass spec panels. The sensitivity of both approaches 100%. The specificity is a little less good, 85 to 90%, which means about 10 to 15% of individuals who do not have a true pheochromocytoma or paraganglioma will have a positive biochemistry. And what I mean by positive, false positive, is that it will be slightly above the upper limit of the reference range, but it's not a true pheochromocytoma. Okay, and that could be norepinephrine, usually elevations due to anxiety, stress, pain, or the use of antidepressants like tricyclic antidepressants or serotonin or norepinephrine reuptake inhibitors, because all of these factors can increase your norepinephrine levels a little bit and increase normetanephrine and metanephrine levels a little bit. But that's not what you're looking for. In someone with symptoms suggestive of a pheochromocytoma, you should see pretty dramatic elevations above the upper limit of the reference range of metanephrines, usually 4-fold or higher, at minimum 2-fold. Whereas most false positives caused by anxiety or stress or antidepressant medications are less than 2-fold. So the upper limit of the reference range is not a diagnostic threshold. It's a rough threshold, but sometimes you can exceed that due to medication or anxiety-related events. On the other hand, the negative predictive value is almost 100%, meaning if the result comes back within this reference range, you can be almost 100% sure that the symptoms are not due to a pheo or a paraganglioma. So this patient had these symptoms of sweating and anxiety. You can see that the plasma metanephrine show a normal metanephrine fraction. This is the epinephrine metabolite, but a normetanephrine fraction, this is the norepinephrine metabolite, that's about 4-fold elevated. And we also did a urine that shows almost a 10-fold elevation in norepinephrine and a 3-fold elevation in normetanephrine. So these are pretty dramatic elevations in normetanephrine in the blood and in the urine. And this confirms the diagnosis of a pheochromocytoma, catecholamine-producing tumor of the adrenal medulla. So now you can localize it, and you can see on imaging, this is a scan that shows on the right adrenal, there's a 2-centimeter mass that's lipid poor. It's greater than 10 Hounsfield units. On an MRI, it might appear T2 hyperintense. So this woman was alpha blocked and hydrated in preparation for surgery. She had a laparoscopic right adrenalectomy that went without complication, and the pathology confirmed a pheochromocytoma. And amazingly, after the surgery, all of her symptoms, the sweating, anxiety, symptoms that she had just thought were her new baseline, completely resolved. Her blood pressure normalized. So this is an example of a pheochromocytoma presenting with pretty mundane symptoms that are often ignored or are not linked with catecholamine excess. Okay, this is the last case, case 5, and this is almost a test case to see whether everything we went through in this lecture made sense. This is a 37-year-old woman, healthy, no medical issues, who had an abdominal CAT scan for acute right lower quadrant pain. The cause of the abdominal pain was not found, but there were some incidental findings. One incidental finding was that on the right adrenal, there was a 2.8 centimeter mass, and it had an unenhanced attenuation of 10 Hounsfield units, less than 10 Hounsfield units. And on the left adrenal, there was about 3 centimeter mass, and the unenhanced CT attenuation was 18 Hounsfield units. And so she was told that these are likely benign adenomas, which is statistically true, and that she should follow up in 1 year. So here they are, okay? So take a look. Here's the right adrenal mass. It's 2.8 centimeters, and it's less than 10 Hounsfield units. You can tell it's pretty dark, okay? So it looks fatty. Here is the left adrenal mass. It's round, it's about 3 centimeters, and it's 18 Hounsfield units. So ask yourself, what would you recommend for her? Okay, or how would you approach this situation based on what we've gone over? I'll let you think about it for a minute. And then we'll review what we talked about earlier. Okay, so where are we in this diagnostic algorithm? Okay, so there's actually 2 masses. The right adrenal mass has reassuring features. It's relatively small or medium-sized, it's round, it's homogeneous, it's less than 10 Hounsfield units. It looks like a benign adrenocortical adenoma, and the recommendation for that is don't worry about it. There's no reason to repeat imaging. This does not look malignant, but we should probably do some biochemical testing that we haven't done just to make sure there's no cortisol excess or other. The left adrenal mass, though, is not reassuring. It doesn't mean it's malignant, but it's not clearly lipid rich, so it has a few suspicious features. 18 Hounsfield units is not less than 10. So you could worry that this needs more follow-up. So you could say, maybe we should operate on it and take it out and see what it is. Maybe we should take another picture in a couple of months. One way or the other, you should not let this one go. Okay, so that's not what happened to her. She was told to come back in a year. She actually returned 1.5 years later. She still felt fine. She had no obvious symptoms. Now a biochemical evaluation was done, 1 milligram dexamethasone suppression test, plasma metanephrine, since one of the masses was not lipid rich, both normal. And then repeat imaging was done 1.5 years later. And you can see that 1.5 years later, the right adrenal mass is unchanged. It's still a 2.8 centimeter, less than 10 Hounsfield unit mass. So it was lipid rich, adenoma appearing, and you wouldn't have imaged it again. And if you hadn't, you would have been right. Nothing happened here. But the left adrenal mass really warranted closer attention because it had some concerning or suspicious features, and you could see it has changed. In this 1.5 year period, it has grown to 4.3 centimeters. Its attenuation now is 30 Hounsfield units, even more dense and concerning. It's larger, it's heterogeneous, and it had some nodularity and fat stranding. So it wasn't smooth and round, and there were some features suggesting maybe invasion or inflammation around it. So now we're concerned. Now we definitely need to take this out for concern of a potential malignancy. And she had an open radical left adrenalectomy, which revealed a potential nightmare scenario, which is that this was a high-grade adrenocortical carcinoma, maybe the silver lining being that it was only stage 1. I won't say much about adrenocortical carcinoma other than to say that it is not common. Adrenal malignancies are not common, but it is a highly aggressive, very lethal, fast-growing tumor, which is one of the reasons we have to have a healthy fear of missing this diagnosis. In addition, the only known cure for adrenocortical carcinoma is early recognition and a radical resection. In other words, this window of opportunity cannot be missed. And once it's missed, it's really unfortunate because if they recur or they come back or there's an incomplete resection, there's no cure. And I'll finish with that and review the take-home points, which were that the adrenal glands synthesize and secrete hormones that play a vital role in hemodynamic hemostasis, namely cortisol and aldosterone. Understanding the physiology of adrenal hormone feedback and the relative interpretations of adrenal testing is crucial on how to make accurate assessments. For example, carefully timed morning cortisol and ACTH can help you decipher whether the entire hypothalamic pituitary adrenal axis is functioning appropriately. And if needed, you can do a gold standard cosentropin stimulation test. The prevalence of adrenal masses increases. It particularly increases with age, and they're very common. And their incidental discovery is increasing year after year. Every adrenal mass should be carefully assessed for potential malignancy and potential hormone hyperfunction. You can do that yourself or work with one of your endocrine colleagues, but don't ignore these masses if you see them. I think that's one of the big problems that we're having in the field. And at any time, you can feel free to consult your endocrine or adrenal expert colleagues to help you out. Again, here are some references and links to the YouTube videos that parallel this lecture, and I hope you find them helpful. Thank you.